All right, good evening and welcome once more to uh, a special event on the Grand Rounds, examining the future of cardiology. I'm really thrilled and delighted that today we are going to today we'll examine the future in the field of electrophysiology, a specific area. And we have a wonderful guest speaker, a great friend, and a group of panelists who will be examining the field. But before going in, I will go ahead and share the screen to show some of the aspects of the cardiology grand rounds. We are having all the grand rounds on the webpage in the division, and you can go there and look there for the old recordings. And as we all know that we provide CME credits for this particular session. To get the CME credit now, please go ahead and text 12447 to the number 888-816-4893. 12447 to the number 888-816-4893. And it's got to be an SMS message. And you need to have an active profile in the Rutgers Cloud CME. In addition to the CME credit, we do provide also MOC credits for the physicians. For this, we complete the step one. And after this presentation concludes, you'll have to go into the web link provided here. And the room code is future05. Future05. You answer the question that is placed there. And if you're correctly able to answer the question, then you will be having MOC point, which will directly go to your ABIM. Of course, it's mandatory that for getting the credit, you need to have a profile in the Cloud CME. And also, along with that, you need to have your own date of birth and ABIM ID that is provided in. So for today's grand rounds, I have the distinct pleasure to introduce Dr. Suraj Kappa. Dr. Suraj Kappa is a close friend of mine, and I have known him ever since he started his residency. We were a couple of years together and going through our initial formative years in Mayo Clinic. Ever since then, he has really become a force in electrophysiology at Mayo Clinic. He's currently an assistant professor of medicine and a consultant in the Division of Heart Rhythm Services in the Department of Cardiovascular Medicine at the Mayo Clinic, Rochester. And specifically, he has a niche leadership role as the director of the Virtual Reality Innovation Groups. And he also is the medical director for the AI for Knowledge Management and Discovery. Now, he has his origin from New Jersey, where he did his MD in New Jersey Medical School in Newark. So he's coming back to the same home crowd. So that's wonderful to have him back. And subsequent to his school, he went to Mayo Clinic, where he did his internal medicine residency, and then subsequently continued his training in fellowship in cardiovascular diseases and fellowship in clinical cardiac electrophysiology at the University of Pennsylvania. One of the hallmarks of Dr. Kappa's abilities is his unique innovation and entrepreneurial abilities. He has an extensive background in mathematical modeling. He is knowing what is called as quantum mechanics, and he knows computer simulation and modeling, and he has worked in the modeling of cardiac activation. And you can see that that's the reason why Mayo Clinic went ahead and made him responsible for enterprise-wide effort related to communications and marketing strategies for innovations in cardiology. And he went ahead with a big paradigm shift in Mayo Clinic, where he branded the clinic's entrepreneurial activity to develop strategic partnership with other groups like Facebook, American Heart Association, Medscape, WebMD, and really innovated in the social media space as well. Cumulatively, he has been a force in the literature that has been created recently in Mayo Clinic. You've seen his name in multiple AI strategies that Mayo Clinic recently has performed and where he's going to talk to us about. But overall, he has close to about 200 publications. And in addition to all the work that he does in innovation, he's also extremely busy in his clinical practice. He's one of the highest volumes practitioner for VT ablation at Mayo Clinic. So you can imagine the amount of work and the credibility that he has achieved. And it's been a great privilege for me to interact with him over the last few years as I've tried to understand my own work in the application of AI in electrophysiology. So welcome, Suraj. It's wonderful to have you here with us.
Thank you so much, Partho. It's a pleasure being here. It's an honor being able to speak to this group.
Awesome. Along with this presentation, we will have also a panel discussion. And for the panelists, I thought I will bring in Dr. Kouroumalis, James Kouroumalis, Professor of Medicine, Chief of Cardiology, a very well-known personality amongst all of us here. Particularly his teaching and his daily activities with the fellows has to be something that one needs to witness. And I've really enjoyed taking the baton for cardiology leadership from him, but also he has helped me to continue the spirit of education and the environment that he creates every day. And this has been wonderful to have him with us. So Dr. Kouroumalis needs no further introduction. Everybody knows him here. So welcome, Jim, to the Grand Bros as a panelist. And along with Jim, I'm also equally eager and enthused to introduce Dr. Shubha Gowda. Shubha is a tremendous asset for us. She's an innovator, entrepreneur. She has been associated with the electrophysiology workforce in New Brunswick area since 2005. And she's a leader with a very high volume electrophysiology practice. And I think together with her, we will examine the future of electrophysiology. And I think we are going to go to some basic application on how AI and opportunities that it's offering to change the landscape of electrophysiology. With those words, I'm going to now pass it over to Suraj for his presentation today. Suraj.
Thank you so much, Partho. And again, it's an honor being able to speak to this group. So today I've been tasked with talking about machine learning and electrophysiology and kind of discussing how far we've come, but I also want to speak to how far we can go. And these are several disclosures, which will be touched on here, but nothing that has generated any specific IP. So as an outline, I know over the series of talks that Dr. Sengupta has laid out, people have been touching on what we actually mean by artificial intelligence and machine learning. And I'm going to touch on that again here, because I think it's always important to recontextualize what we really mean by it. Then we'll go through evolving applications to electrophysiology. And when I say that, I actually extend this from electrocardiology all the way through invasive electrophysiology. And then finally, I want to touch on where do we actually need to go from here? The concept of artificial intelligence and this principle of augmented vision is nothing new. I mean, in truth to form, there's in ancient Greece the concept of automatons, essentially these creatures that were made out of earth and metals that could actually have a semblance of personal thought that humans can create. But really in the modern parlance of computers in the current day format that can actually have the capability of quote unquote thinking on their own really came about in the 1950s when Alan Turing coined the term related to artificial intelligence. And this was followed by the workshop at Dartmouth that really coined a lot of the principles that underlay what we think artificial intelligence should actually mean and when we achieve it. And really, it's not new in terms of people claiming that artificial intelligence is here right now. In the 1958 New York Times, there was an article published about this new Navy device that learns by doing. And to keep it very short, Basically, the first sentence is the Navy revealed the embryo of an electronic computer today that it expects will be able to walk, talk, see, write, reproduce itself, and be conscious of its own existence. And obviously, we were not there yet. And frankly, we're not even here now. But it's important to understand this in the context of why these principles of artificial intelligence and machine learning, despite the fact that they've been in science fiction and also movies really for decades, why they're really coming to bear now in our current practice. If you look at the history of AI from 1940 to 2000, you can easily graph the impact that it's had over the course of the decades. It was really during Japan's fifth generation computer project that things really took off in terms of the potential for artificial intelligence before it actually tailed off in the late 1980s. Up till we got to the 1990s when Deep Blue beat Garry Kasparov, and there was this renewed interest in the possibility that artificial intelligence and advanced approaches to machine learning that could potentially challenge traditional human paradigms of what requires the most complex degrees of thought would actually be feasible using artificial intelligence systems. And the reason that's been possible is because of the extraordinary exponential improvements in computing power at smaller and smaller form factors. Even if we go back to the early 2000s, if you actually think about where we were, even with the most current supercomputer, we've already passed the best supercomputer in the late 90s and early 2000s with what we're capable of with a desktop computer or even potentially a mobile system. And now with the cloud-based architectures that exist, we're able to actually create systems that don't require hard-based systems in one specific location, and thus can actually operate at scale and function at scale. I do think it's important when we talk about all this to touch on one key point. I'm not going to go into too much detail about this, but I think it's really important to think about this, especially in academic structures where we're trying to employ artificial intelligence, machine learning, that it really is a continuum. When we think about machine learning, it's a subset of what artificial intelligence could be. And essentially, what it often depends on is some degree of feature extraction that's human engineered. In other words, humans in the loop that are actually going to say what features to look at. But using those, we're able to create these very complex nonlinear models that result in specific outcomes that might be better than our traditional algorithmic approaches. So what do I mean by that? If we think, for example, about stroke risk with the CHADS-VASc, does any one of us really think that at 64 years, 11 months, and 29 days, the next day, all of a sudden, your stroke risk goes up? I don't think any of us really believes that. Well, rather, we probably have in place a gradual increase that has occasional inflection points that result in increased risk. The problem is at a human level, we're not going to be capable of accounting for that degree of mathematics to plug in each particular characteristic to get to such a complex output measure. But at a computer level, inputting all these on its own, it's much more likely. Deep learning is a slightly different concept that tries to take out the human engineered portion of it. Basically, it says, let's just expose a computer to as much data, as much paired data as possible, and let's allow it to figure out the resemblances, the associations, and everything else. Obviously, this is heavily reliant on the data being robust, clean, etc. However, in principle, by taking the human out of the loop, it might allow us to actually get to even greater degrees of accuracy. A way to think about this is deep learning learns the way a baby learns. Through repeated exposure to faces, to individuals and whatnot, it will gradually come to understand who's whom, words, sentences, complex structures, that we don't really spend conscious effort necessarily trying to push that upon them at all times. They seem to learn on their own, oftentimes even beyond what we try to show them. And that's one way to think about this continuum of machine to deep learning. So if we look at the present time, this is again, this evolution of computer power and cost. And I think the key point here is it's not just the question of exponential ability to compute at high rates, it's also the decreasing cost associated with that. The concept of GPUs, or graphical processing units, from NVIDIA and others has absolutely transformed the cost structure to actually do artificial intelligence-like approaches, to the point that even my nephew, who's 15 years old, has his own computer where he's doing his own deep learning projects in his house without really requiring any special software, and really built it on his own. Ultimately, what we're trying to do is we're trying to take these complex structures, and it allows us to take these eminently complex structures and create meaning out of them. And the way I would think about that is in the way that many expert senior people in medicine are able to look at data and come to concrete conjectures from that data in ways that even the most educated, high-scoring junior person coming out of residency and fellowship might not be able to. I always give the example of a good mentor of mine, may he rest in peace, Mark Josephson, who basically, he could walk by an ECG and see it projected onto the wall and say, oh, that's Miss So-and-so, without ever seeing the name. Or that's actually from a 20-ish something year old woman, except they seem pretty sick. But no matter how much hand waving he offered to try and explain what he was seeing, he could never really explain it in a way that any of us could ever come to saying, okay, yeah, that makes sense. Okay, now we can do this on our own. And that's really what this vast amount of integrated computing power will let us do. It takes the abstract and might allow it to offer concrete understanding for those who might not have had that level of exposure. And really, with this improvement in the capabilities of computers, what's happened is the neural networks of the 1980s have advanced to the point where there's so many hidden layers and abilities to process that it's actually improved the overall accuracy of what can result from a given input. And really how far we've come. This is the Raspberry Pi. And with this particular very small computer system, they showed that they were able to create an algorithm that can identify umbrellas, the pink boxes, people, the green boxes, and cars, the blue boxes, automatically just using this computer in real-time visualization of an environment. And that's extraordinary if you think about it, at the small scale of that computer system being able to do something that frankly could never have been conjectured in the old systems of the 1980s. So the question is, what are we doing today and where will we go tomorrow, particularly in electrophysiology? Right now, and this is very important for us to think about in the examples I'm going to be giving you, we're really in this area of largely weak AI, and maybe to some level of cold, strong AI. But really where we are is we're actually providing levels of data and finding relationships amongst that data. We're not getting to logical reasoning, global learning abilities, or even this concepts of self-consciousness or biological neurons. In fact, there's still debate what that actually means in the context of intelligence. Really, we're operating in this area of weak AI, in the simulation of intelligence, giving data and allowing a computer system to come to certain conjectures based on that data. There's certain myths we need to think about. The myth that AI will replace some or most doctors. I wholly disagree with this, even in the context of radiologic interpretation or other areas. This is one of the most recent examples of using artificial intelligence to tell the difference between a chihuahua and a blueberry donut, or a blueberry muffin. And the reality is the AUC, the area under the curve for accuracy of analyzing these, often does not surpass 0.90 or 90%. I'm using a crude measure. So that tells us there still needs some evolution from a human in the loop perspective, and whether that means more data exposure or something else, we have to see. AI is hard because of the analysis to be done. The truth is, so much has evolved in AI that actually in the Lancet just a few years ago, there was a publication where physicians actually published an article showing the creation of a deep learning neural network using open source technology without ever engaging a data scientist. They just had access to their own data and produced their own neural network. And the reality is, with the evolution of technologies and software that allow users to very easily do it on their own, it's similar to the creation of new apps in the app stores that we have. You see more and more people with just a semblance of computer knowledge, but not extraordinary computer knowledge, creating these extraordinary applications without actually having to depend on the most advanced computer scientists. And finally, the concept that AI will somehow dehumanize medicine more than it already is. People look at the advent of EHRs and how much time physicians spend looking at those and worry that AI will take people even more away from the patient. I would actually debate something different to that. I would say AI allowing data to be shown more cleanly and more effortlessly to clinicians at the point of care might allow them to interface with data in a much cleaner way, in a much more humane way, and humanistic way. So their time is spent talking to the patient rather than searching for the data. There's several learning techniques that are being employed, and all of these are different extremes of prediction accuracy given away with explainability. Much of what I'm going to be talking about today is what we've done in the deep learning space, where we have great accuracy oftentimes, but unfortunately we give up some on the explainability. So there's a lot of efforts undergoing right now to improve explainability of these deep learning models. But to be honest, when you read a manuscript about machine learning, artificial intelligence, technically decision trees, random forests, logistic regression all fall within the realm of machine learning. But that doesn't mean that they're less than deep learning or something else. They're just alternative ways of looking at the data that gives up sometimes accuracy for explainability, but not always. Data in medicine takes many forms: that which we read, that which we see or feel, that which we order, and that which we take to the lab and figure out after the fact. The problem is our ability to integrate all of this. And ultimately, at the provider level, costs are increasing. Fact is, medicine is much more expensive to engage in than it ever was before. But biomedical data is becoming ever cheaper and more democratized at the consumer level. One of the reasons we focus so much on the AI application to ECG is, as I think many of us know, there's so many form factors, watches and smartphones that can allow a consumer to order a technology that can allow them to get their own ECG without ever having become a patient, without ever having engaged with a cardiologist or even a primary doctor. And now they're getting this data, and the question is how to operate with it. So what are potential applications to electrophysiology? There are obvious non-invasive applications. Radiologists will probably go over a lot about the imaging, and so I'm not going to delve too much into there. But within imaging, we think about interpretation of the data, interpretation of the read. There's diagnostics in terms of more rapid solutions to the things we're seeing on the diagnostic modalities, even things like patient identification. And then there's invasive approaches within electrophysiology, signal optimization. How do we clean up the signals we see in the lab better? And also procedural guidance. Can we allow people who have done, say, thousands of VT ablations to inform the new graduate from an electrophysiology program who might be doing their fourth on their own, but needs some of the guidance that someone else who might be able to provide, but can't be physically there to provide it? And ultimately, we're trying to advance beyond the humanly visible signal. I gave the example before of Dr. Josephson looking at an ECG. And this is this concept of evidence-based medicine, or I would say the algorithmic-based medicine, where I can explain to you exactly why a right bundle branch block looks like a right bundle branch block, but taking that to the extreme of talking about intelligence-based medicine. In other words, that deep intelligence that comes from repeated exposure that the most expert and advanced and senior people will be able to provide, that to the junior person coming out of residency, fellowship, med school, wonder, how in the world did you come up with that? Because I never saw that, or I never heard about that. So to first touch on AI-enhanced ECG interpretation, we know how we often read ECGs. We call it normal sinus rhythm. We talk about the axis of the QRS. We talk about the QT interval, the PR interval, and we try to come to some semblance of whether or not there's disease. In one way in which AI can help with this is streamlining human capabilities. We think about first pass interpretations, improving the interpretations provided by the system. I'll give a great example. Just last week, I had a patient who I randomly got called to the device area saying, hey, this person's rhythm seems funny. We had an ECG from the day before, which was called atrial fibrillation, right bundle branch block, left anterior fascicular block. I didn't look at the ECG, but I looked at the device, it was VT. And then I looked at the ECG as well. It looked like no typical right bundle, left anterior fascicular block you would ever see, and there was clear AV dissociation. So the thing is, if you can improve first pass interpretation, that might actually save a patient an occasion. But the question is, can we go beyond human capabilities? Can we get greater insights from data, from the ECG, beyond what we traditionally seek? in what we do every day when we actually write a read on an ECG. So this is an example for an ECG from a patient, sinus tachycardia, and we looked at, can we identify certain features from this ECG? One of the first things we looked at is, can we identify whether or not somebody might have a low heart function just from the ECG alone? In addition, we tried to see if we have a normal sinus ECG, can we predict what the likelihood of them having atrial fibrillation is? And I'll touch base on this very briefly, but we also looked at, hey, can we actually figure out how old they are from the ECG biologically as opposed to just chronologically? And there's several other algorithms we developed over the years, but I'll focus on these three just to be brief. With low heart function, what we showed was just with a 10-second 12-lead ECG alone, we had an area under the curve of 0.93 to predict whether or not somebody has an ejection fraction of less than or equal to 40%. From a normal sinus rhythm ECG, we showed we could predict whether or not somebody had atrial fibrillation within about 2 years of that normal sinus ECG with an AUC of as high as 0.9. And just for context, when we think in medicine of a perfect test, an AUC would be 1.0, which means that you never really expect perfection with anything we do in medicine, but it does compare favorably with other medical screening tests. Mammography for breast cancer has an AUC of 0.85. PSA, you can debate, is 0.92, but obviously we know we overdiagnose that to a great degree. But one interesting thing that we saw when we were doing these studies is we tried to get the scores to be even better. And we said, well, everything in cardiology shows that if you input gender and age, the model gets better. So we tried to do that and it had no impact. So we decided to say, okay, is it somehow seeing that in the back end? And we know that the ECG does change as people get older. And what we showed is looking at over 1 million independent individuals, there seemed to be the ability of the system to predict how old somebody is within about 7 years of their actual chronologic age. But what was more interesting is deviations from that age seemed to correlate with how sick they were. In this particular patient's case, at the age of 38, their ECG age was approximately in their 50s and continued to increase over time. This was a patient with familial hypercholesterolemia, had multiple heart attacks already by the age of 38. And then all of a sudden, at age 54, we see the sudden decline in their ECG predicted age, which actually correlated with them getting a heart transplant from an 18-year-old. And it didn't quite fall to where we would say, okay, it's the heart alone that's defining this. There might be other factors, heart rate variability related to autonomic shifts and other factors that correlate with that change we might see in the ECG predicted age, which we're still looking at. But what's more interesting is we started looking at what the implication of a false positive result is. And what we showed was that in the case of these false positives, there's about a 3 to 4 times risk of subsequently developing a low ejection fraction on future echoes. In other words, at the index point in time where we looked at paired ECG echoes, and we said, okay, well, the echo actually showed an EF of 55%, though ECG thought the EF was low. The patients who had that positive result had a 3 to 4 times increased risk of developing a low EF over long-term follow-up. This is up to 15 years post-follow-up. And in fact, we're seeing the same thing in other diseases, like in pulmonary hypertension, where we see something very similar, where we're finding that we might be able to identify the presence of pulmonary hypertension as confirmed by right heart cath as much as 3 years prior to the index diagnosis. But what are some of the principal questions in invasive electrophysiology? And I think there are really 2 that we're really focusing on right now, but there's other areas that I'll touch on. One is, how do we optimize skill for maybe low volume proceduralists or people who haven't been as exposed to a particular area of electrophysiology? You're using a mapping system you've never used before, or a catheter you've never used before. And you're looking for that same level of insight that maybe the first person to ever use it, who's done 1,000 cases with it, has, but they can't be in the room with you, or they can't be in the room with every single case. How do we use those insights that can be automatically garnered from how people function and operate on the data that's presented to them to give further advice to others? A very simplistic concept behind this is the definition of a lava potential in electrophysiology, or essentially an abnormal signal based on signal characteristics that might suggest that you're in an area that might result in VT or be a propagation site for VT. How do we turn to somebody and allow them to get that same insight that this is a relevant spot to ablate, as would some of the most senior people who first coined the term. Because I definitely have seen examples where they'll come into a lab, even of people who are middle to even late career in another lab, and say, oh yeah, I wouldn't actually ablate there. And they'll say, well, this is the definition of this type of potential according to all the publications you wrote. And they'll say, well, yeah, but no, we just had to simplify it. But that technically doesn't count. And that becomes tricky to explain in an algorithmic way to individuals. The other issue is whether or not noise is actually noise. If anybody's been in the electrophysiology lab, they'll see so many examples where we adjust filters and push them up or push them down in order to get rid of these baseline noise. But by doing so, we're often losing data in the process, data that could be relevant to the understanding of the electrophysiologic milieu. And the question is, when we start extracting noise to make it more intelligible for the human user, are we losing fidelity for human biology, focusing on humanly interpretable and visible signals? We want to make it more user-friendly for the human by extracting data that might nevertheless reflect biology. And how do we harness computing technology to thus see beyond noise and extract and understand what it is? Ultimately, when we think about the signal processing wish list, we ultimately would love a system that can automatically detect what the source of noise is, what's actually contributing to every signal we see. Can we improve the signal to noise ratio so that we can understand what's going on as well? Can we automatically identify specific electrograms and the relevance to arrhythmia maintenance, like the lava example I gave earlier? Importantly, can we integrate multi-parametric generated maps and images with what we're seeing invasively? The truth is, in electrophysiology, when I do a VT ablation, I often will have an echo plus strain imaging on the echo, plus a delayed enhancement MRI, sometimes an FDG PET to look at areas of inflammation, plus the voltage map I'm doing invasively, and sometimes a VEST approach, do multi-electrode understanding of what's happening within the heart and to map the VT circuit before I go in there. But all of these stand as individualized tools that ideally need to be integrated at the point of care to reach the best possible outcomes. And there's many currently cited applications of ML to atrial fibrillation as the best paradigm of invasive EP where people are focusing their energies. Body surface potential mapping, essentially having people wear vests to see if we can understand the inverse problem of what's contributing to the AF and maybe where we should ablate before we go in there. Single or multi-channel electrograms, understanding the electrograms we're dealing with in a much more unique and kind of elegant way than what we do right now. And procedural skill. Can we, as I explained a couple times before, can we advance procedural ability by using the historical understanding and responses and uses of some of the most expert and some of the most experienced people in the field, such that we can actually distill that to others and actually scale expertise in a much more seamless way. This is an example where groups have actually looked at mechanistic modeling by integrating MRI with personalized simulations of AF induction and looked at the impact on ablation by integrating into their ablation strategy in order to result in improved outcomes by being able to predict the risk of AF recurrence after PBI. In other words, they used all of this data that comes from invasive and preoperative mapping to say, can we use a machine learning approach to have a personalized understanding of the likelihood of this individual having recurrence after the pulmonary vein isolation? And what they showed is by machine learning approaches using only the pre-procedural late gadolinium enhancement MRI, they had an area of the curve as high as 0.82 in terms of predicting the risk of AF recurrence. Now, this becomes so much stronger because the reality is when we talk to so many patients about their atrial fibrillation and their PVI, we often tell them a very broad understanding of what their success rates might be. Paroxysmal, younger, pretty healthy, maybe as high as 80-ish%, maybe a little bit higher. Persistent AFib, older, less healthy, maybe you get to 50 to 60%. Hypertrophic cardiomyopathy, persistent, giant left atrium, much less than that. But it's still a gestalt. And I think we've all had patients who've had a PVI in the worst quote unquote scenario, and they actually did pretty well. And vice versa, when it seemed like the best possible scenario. This is another example of work we've been working on where we said, okay, can we actually clean out the signals during radiofrequency ablation to understand when we create an inadequate lesion without having to rely on any other features like forced time integrals or other aspects. And I won't delve into this too deeply for a general audience, but what we showed is with fairly good accuracy, we were able to understand whether or not the ablation lesion was adequate based on the signal response at the time of ablation. There are several challenges that I'll talk about in the last couple minutes. One is external validity and generalizability. Within Mayo Clinic, which, both Dr. Sengupta and I have been in for many years and know a lot too, the truth is about 90%, 95% of the population is, white, Caucasian, Midwest. So how generalizable are the truths or seeming truths that we get out of the population to other populations, whether around the US or around the world? And we have to consider that, because if we put data in that's only relevant to one specific group, whether it be based on sex, whether it be based on race or even socioeconomic status, whether or not that actually will extend towards others is unclear and can thus actually exacerbate the problems of inequities in medicine. Sometimes it's difficult to assess data input quality at scale. To create good algorithms, we need to have good inputs. And this applies to training if we think about it. If we have teachers who tell us the wrong things over the course of our training, then we're going to have the wrong understanding and we're going to give the wrong results when we're in practice on our own. Similarly, if we give a computer inaccurate data based on inaccurate labels, then that might result in issues with the data input quality that can result in issues with the data output quality. In other words, how the algorithm actually sees things. An example is if we use every echocardiogram and saying, okay, we know which ones show a low EF, but all the low EFs are on patients where the image quality was poor, so it was kind of a guesstimate. How accurate is that when trying to train the AI? There's the black box issue I touched on earlier, which is the issue of explainability. The fact is, in medicine, we want to know and understand exactly why we're doing what we're doing as best we can. But when a computer's sitting there telling us, oh yeah, you should think of this, but we see no reason to do it, the question is, how do you engage people to actually change their behavior in response? And the fact is, there's so much hypothesis generating opportunities within all of this that we want to also leverage from an academic perspective. And finally is the loss of interpretability and the potential risk of actually creating dangerous outputs. It's one thing to say, okay, this AI algorithm suggested that you might have a heart abnormality that requires a non-invasive ultrasound. And now with POCUS and other approaches, they're much more cheap to do and much more cost effective to potentially do, at least at the bedside, quickly. But what about if you're in the EP lab and it's telling you to ablate in a certain place and it was inaccurate and now you're creating scar tissue where you didn't need to? Ultimately, the keys for successful AI in medicine will be reliable large data sets. Ideally, we want to end up in a situation where we don't need human arbitration of diagnoses or endpoints, because that's going to add a human in the loop that could potentially create errors. We want to minimize bias by allowing for large enough and diverse enough data sets. And ultimately, we're going to have to rely on dynamic algorithms with constant updates based on new therapies or outcome interactions. In other words, they can't be static. And that's something the FDA is also going to have to struggle with about how to allow for that. But I'll stop here and leave time for questions. Thank you so much.
Wonderful, Suraj. Thank you very much. Let's get back the panel. And we'll have both Dr. Krimalas and Dr. Gowda join in. So let's do a practical exercise and let's make it more interesting on what this could be for all of us. So Suraj, let me ask you, I mean, I've been with AI. We all know what AI can do. What is Mayo currently? Tell us one or two or three things that you're effectively currently doing in the day-to-day clinical practice in using AI, or any of those algorithms that you have developed now at Mayo.
So one thing is actually within the Epic EHR architecture, we actually have launched all of the AI ECG algorithms in the form of an AI ECG dashboard. So actually every clinician in the institution is able to see what the results of the AI ECG data are. while we're seeking potentially getting to FDA approval on those aspects with further external validation. That way it creates an environment for people to perhaps learn more about what might be happening or actually, perhaps order a test. And we've actually done a pragmatic clinical trial across the general internist groups, looking at the deployment of these AI ECG EF algorithms amongst them to look at the impact on the ordering of echoes, but also the new diagnoses of low EFs, and have shown about a 5% increase in the actual diagnosis of low EF amongst the groups randomized to use or to access to these ECG algorithms. That's one way in which we're doing it practically. The next way which we're looking at is exactly how to deploy it externally, because that's really ultimately, you don't want the benefits of medical science to only exist within the four walls of one brick and mortar enterprise. I mean, that's never been the purpose of anybody's, research in medicine. And that's where Mayo's kind of come into the form factor of creating this Mayo platform to start looking at how can they actually deploy externally and rather than just exist internally. And that's still a point of action that's still evolving.
Okay, so Suraj, I'm very aware of that paper of the randomized trial. I think it was a cluster design in which the AI algorithm was deployed, and you showed that there was more appropriate referral for echocardiography. In fact, the arm where the AI was used, they would increase the referral for echocardiogram, but many of them were more appropriate than the other arm. Now, I want to go ahead and ask Jim a question. So Jim, some early use case scenario, very early evidence, I would say, very important from Mayo Clinic, very groundbreaking work from Mayo Clinic on use. But what do you think about as a clinician educator when you're teaching our fellows, and how are we going to juggle between the traditional way we have approached teaching ECG and now with the approach that is coming? What do you see? Is this a tension? Or do we have to create a bridge, and what those bridge or what those steps would be?
I don't think it's a tension. I mean, when I think about it, and when we think about it, it's amazing, even before we get into artificial intelligence, that, the EKG that Einthoven invented 120 years ago with the string galvanometer, his first EKG, I was just thinking about it this morning. Think of all the information we already get from an EKG, a very simple test, right? 120 years old, where you can diagnose, we use it for acute coronary syndromes and STEMIs and ventricular arrhythmias and just so much, conduction system disease. So this is just another extrapolation of what you can get out of that simple test. I don't think, as long as there's validity and that's established, I don't think there'd be a problem in using something that we can see basically, ourselves and diagnose and use the AI. But I think one caveat, and I think Suraj mentioned it as number two, is the quality of data coming in. Because in my experience, as the EKG, although it's such a, probably the best, dollar for dollar test that we do in cardiology, right? Simple, very cheap. But as it's become sort of cheap, it's also become less of an art. I know in Robert Wood, even when we have dedicated EKG technicians in the hospital I was at previously, sort of how well they did the EKGs was variable. And now, as you spread it out, where a lot of people who not really taught how to appropriately do the EKG, you get a variety of bad data coming in, especially now that we also, since COVID, have expanded so that a 12-lead EKG can be done off a telemetry system where all the leads are sometimes pressed within, like a 12-inch area over the chest. So I just worry, and I don't know what Suraj says about the quality of the data that's coming in to be able to use this.
Yes, it's actually interesting. So one of the things we've actually done internally is when our models work, the way they work is there's actually several levels of confidence metrics that exist within the system to both evaluate the quality of data as well as to actually give an output. Even when I say the low EF model saying yes or no low EF, that's actually really not how it works. It's more of a continuum from 0 to 1. And we create a cutoff value to say, well, below this will probably be highly likely to low EF, but the closer you are to that cutoff, the less likely it is. So there's a strength of value in terms of the perception of a computer on the likelihood of the output being right. But there's actually something along the lines of a quality metric that also exists in terms of the quality of the data coming in. And one of those elements is the computer can actually see whether or not this ECG is representative of ECGs that it's ever seen in terms of its representation. So for example, say it's never seen the lead reversal ECG, but this makes absolutely no sense in terms of what it's seeing compared to every other ECG in its system, then it'll actually, we have a quality metric that can actually throw out something saying, okay, this is a 0 level quality ECG for what I'm trying to predict. So I think that will have to be part of all this, especially when we talk about bias and representation within the data. We'll have to think about how we can allow the computer to know whether or not this is a piece of data representative of data it's ever seen before. Because otherwise you're just forcing the computer to come to an output. Maybe you supply it with an echo still image and tell the computer it's an ECG, but it has to give you an output that has no idea what it actually is because it's never seen it before, but you're forcing it to say something anyway. And that's an extreme example, but that's one of the ways to somewhat address that issue.
I think AI is a great tool for doing that, because when I and many people look at an EKG, sometimes we don't know exactly, but we say, you know, something's wrong. They put the leads in the wrong place. It did this or that. So if we can do that, certainly AI should be able to do it a lot better.
Yeah.
So one of the ways to think is maybe AI should be also thought as a gatekeeper to the quality, right? I mean, that could be a very simple way to look into lead malposition and things like that, where people sometimes struggle to really understand. And let me ask Shahbaz. So Shahbaz, you have a very busy practice, and I know tremendous throughput and efficiency challenges every day we have. Where do you see this all going for your practical uptake? You know what I'm saying? Yeah, it's all good that the AI. How do you think we should, let's say in Robert Wood Johnson, our health system, where do you think this comes? And will it make a difference, or do you think we need to do something, rethink the whole way we're going to launch an AI applicability in ECG or during ablation? What do we do? Very broad.
Thank you. I would really like to first thank a lot of people. First of all, Dr. Sengupta, thank you for arranging it. And thanks for having me on the panel. Dr. Kappa, very sophisticated, and boy, a presentation that really picked a lot of my interest, not just my interest, but a lot of questions. And I'm going to ask you a lot of questions and probably demand a few things.
Yeah.
So it's very amazing how far we have come, but yet not. In the sense, like Dr. Coromillis said, it's been over a century with our Einthoven's triangle and ECGs, and we have now computers interpreting ECGs, which are actually very close to accuracy compared to about a decade ago. So the computer interpretation of the EKGs that comes up on the top, I definitely have noticed a lot more accuracy in today's computer interpretations compared to a couple decades, or at least a decade ago, or definitely a couple decades ago. Having come this far on the regular ECG interpretation, I'm kind of surprised how we took this long to get into the Cardia, or the Cardia technology being integrated to the Apple Watches to do, because that's all based on the same AI technology. Isn't that correct? Having said that, I'll actually ask my questions later. Let me answer Dr. Sengupta's question first. Definitely we at Robert Wood would love to collaborate for a lot of things. We would love to enroll our patients if you have studies. We can do this now with the age of Zoom, and we're doing the grand rounds on Zoom, which we never had thought of before 2020. So if we could remotely, our research coordinators, our office patients, clinical patients, both university and private community physician patients, we can enroll our patients to any of the studies you have, and we can do this remotely. Our research coordinators can follow up remotely. We can also do meta-analysis and write up a few review articles along with you. We would love to do that. And also maybe you should consider having us part of your multi-center trials, and I would love to do that. The panel discussion today is definitely a great start for all of that. So Dr. Sengupta, I definitely think there is a role of AI in everyday practice, private or academic, in whatever setting. Absolutely do not feel threatened by it. AI will never take away the job of physicians. It'll only help us to be a lot more efficient. But my questions now, I'm coming to you, Dr. Kappa. How come we are so behind? Because in BARD or in the PRUCA, in the EP lab, once we induce a SVT, let's just say, how come we don't have the algorithms like the computer interpretation of the ECGs, where our mapping systems, forget the 3D mapping, we'll just talk about the ECG systems of a BARD or a PRUCA, doing the algorithms, spacing algorithms, a potential diagnosis of the kind of SVT, that's one. And then we can have 3D mapping systems where the catheters themselves do AI and map the PVs, pulmonary veins, the left atrium, and the origins. A lot of it has actually come a long way in our 3D mapping systems for ablations. Where do you think, how far do we think we are to do more AI in the EP lab after induction of an SVT, or in mapping systems to integrate it a lot more? But I definitely am very, very amazed with your entire presentation and how far we have come. And thanks for thinking, because what I really would think is, even though I'm an EP, I have a lot of passion for prevention of sudden cardiac death, because that's how I lost my grandma. I would really like to have a system where a patient with a chest pain can have a 6-lead EKG, or preferably a 12-lead. Now we have 6-lead. Get an EKG just through his smartphone, because the cardia strips, now you can put your EKGs and get almost a 6-lead EKG. Can we get an EKG and they can be radioed into the ERs, to the urgent cares? And in that way, we can prevent out of the hospital cardiac arrest, because most of the arrests that don't survive are the ones that arrest out of the hospital and don't make it to the hospital. I think if they make it to the hospital, the chance of survival is much higher. So too many questions, but I hope you can help me out, and would love to see where we can go.
Yeah. No, so those are all excellent questions. So, actually I'll touch on the second set of questions first, since they dovetail a lot on what we talked about, and then touch on the first set afterwards. So I didn't present this here just for purposes of space and time, but what we've been doing is we've actually been taking the 12-lead ECGs and looking at how they would operate if we only had a single lead or only the limb leads, and actually then doing validation studies on some of these other mobile form factors for ECG acquisition. So the EF algorithm is probably the best one of that, because it's been around the longest, but we've shown that the accuracy is actually nearly identical, maybe a little bit of a loss, like an AUC of like 0.88 as opposed to 0.93. Or even 0.90, depending on the form factor. When you do a single lead, lead 1 ECG, which is the traditional that you get out of, the Apple Watch or things like that, as opposed to if you get a 6-lead where the accuracy is essentially no different from what you get from the 12-lead ECG. One study that we actually is published as an abstract, the paper is still under review, showed that there's a stethoscope that has an integrated ECG form factor called Echo, that we show that, in fact, using that, or AOC for detection of low EF, was about 0.91, just using that. So the reality is that I think we're evolving to where these other, more consumer-enabled form factors, or more nimbly enabled form factors, will allow for somewhat equivalent diagnosis. But I think this needs to be validated across each algorithm as it comes out, and we need to create better ways of validating it. So for example, is it enough to say, okay, if we only had 1 lead from this 12-lead ECG, what would the accuracy have been? Is that enough to say the accuracy will project across all other form factors or not? Because the truth of the matter is, the best annotated cohorts that we have are off of 12-lead ECGs, right? That's where all the data, at least to date, largely exists for us to develop these machine learning and deep learning approaches. The data will evolve as time goes forward, and we have more and more people who have single lead, 6-lead ECGs, mobile form factor ECGs, to pair against prospectively obtained data. And I think we need to be thoughtful about how that's obtained and how it's integrated and allied with other data that we get through routine clinical architectures. But until we do that, we're going to be dependent on these older form factors, which gets us actually to the first point you brought up about the Pruka and about the mapping systems. I know there's a lot of interest, especially on the mapping system side, to look into integrating machine learning, AI approaches in order to optimize feedback to the individual, even optimize how mapping itself is done. On the Pruka system, I think the biggest issue is just interest more than anything else. It's whether or not somebody actually takes the effort to go back into their studies, download all of the studies as a digital files, annotate them in a cohort of them, and then looking at whether or not they are accurate.
Yeah.
That's the thing. And we haven't tried to do that within Mayo. And as far as I know, nobody's really tried to specifically do that, but it's by all means something that's reasonable to do. The question is whether or not companies to do it themselves will actually see it as increased value to offer that through their system. And number two, even if they thought it was useful, the fact is most of the time the data as it exists is owned by the institutions where the data has been, produced. So even if a company like a GE, like any other Medtronic or anybody else wanted to do that, they would have to ask the hospitals to gain access to the raw data that's well annotated, that has the annotations of the individuals who are using that data. And this might change over time. In fact, there's a good example in the language world. So a good friend of mine works in this kind of very open source AI world. And they actually trained a language model without any human annotation through something called unsupervised learning on the entirety of language in the internet. So the public facing internet, it was just shown the entire English language. And actually it's incredible the degree to which it can understand questions and actually give what sound like reasonable responses. You can ask, who do you think will win, the 2022 election for governor of, New Jersey? And it'll actually give, a paragraph response talking about the two candidates on its own without any human oversight. So there is some interesting elements that are evolving in that space. The mapping system side, unfortunately, is has as much of an issue as the Pruka side, if not a little bit more, because the older, when you go to the early days, Cardo's kind of been the workhorse for a lot of us, and especially advanced electrophysiologic mapping. Traditionally, it didn't save the raw signals that you get throughout the entire case. It saved whatever you annotated, and it didn't save the raw
Anatomical
signals.
variations also play a factor. And that's something that can completely skew and deviate.
Yeah, exactly.
I'm just surprised that somebody has not, but I see your point. It's probably going to take a lot of effort, time, with probably not enough reward for these companies to sit and write the algorithms, because just like how a computer interpretation of the ECGs came by, it needed somebody to sit and annotate and write the algorithms and the protocols for the computers to generate, the ECG machines to generate the computer interpretations. But it's quite interesting, very exciting, and looking forward to new innovations. And EP is the youngest branch of cardiology, or maybe not. Now we have a lot of new subdivisions in multiple different imaging and structural heart. So can't say we are the youngest, but it's still a lot of exciting times, and would love to collaborate with you.
Absolutely.
Multifold
in any levels.
And Shiva, one of the things that we could do probably is if some of those questions that you're bringing in are actually some of the areas that we can work together and maybe create multi-institutional databases within the Barnabas Health system. And there are so many operators, and imagine the possibilities. It all requires just orchestrating it and bringing people together and getting it done. But these are all the questions that need to be taken up. I do have one more question. Jim, you wanted to say something.
I was just going to say, they're probably working on this already, but you can do the body, I can imagine AI with body surface ECG mapping with the inverse solution, and then stereotactic radiation, where basically the whole thing would be done, done
without
with
radiation.
AI almost, including the procedure.
Yes, yes. I mean, that's an exciting. Now, let me ask you to something more mundane. Devices. We do so many devices like ICDs and all, but many of these ICDs are never used in lifetimes. So, don't you think there is a need for us to better patient selection and identifying the ones that really deserve it? Because right now we just go by some guidelines, but they don't really do a justice, and we end up so much of CRT and ICDs are utilized without really there being an effective outcome. How do we
Well,
address that? Suraj, do you want to
Dr.
address
Carper to speak about that first.
that?
well, that dovetails directly off what Dr. Gowda actually brought up just before about her grandmother dying suddenly. I mean, the truth is, when you think about that iceberg example I showed about intelligence, that applies directly to sudden death. But it applies both ways to the sudden death we predict a risk of, but never use anything, and also the sudden death we never understand or recognize that nevertheless happens despite our lack of recognition. And there's probably a lot that's hidden within the ECG that becomes relevant to that. I mean, when Mike Simpson came out with signal averaged ECG, we used that for a while, and then we kind of fell out of favor, saying like all these other clinical trials give us just as much, if not better, understanding of risk stratification, but does it really? And there's a lot of issues related to that. But I think there is value in integrative approaches for data to understand what the actual risk of sudden death is, of ventricular arrhythmia risk, which again also does probably shift over time. I mean, we know from I-123 MIBG imaging, and a lot was been done in MGH about prediction of sudden death risk and VT risk and ischemic cardiomyopathy in patients with low EF, that the degree of hyperinnervation and errors in sympathetic innervation and border zones of scar correlates with likelihood of VT development, which we don't account for within a lot of what we do right now. And part of that's because of ease of use. Part of that's because we always want to err on the side of not missing the one person over necessarily avoiding, say, the 10 people with complications as well, because it's, we worry a lot about, errors of omission over commission sometimes, especially when we can justify why we put it in the first place. So I do think there's opportunities to advance this further. I think, however, simply having a computer system that says, okay, this person has an EF less than 35% on guideline-directed medical therapy, ischemic, EF still persistently low. Let's put an AICD in. If you have an AI algorithm that comes out and says, oh yeah, they probably don't need it, you're probably going to need a rigorous clinical trial that's pretty large to allow people to change their clinical practice. I mean, if we look at what happened with Danish, it didn't really affect what we're choosing to do as far as implantation of ICDs for the most part in non-ischemics. So to say that we're going to bring an ECG algorithm or some other AI algorithm to reconsider, I think we're going to have to do a lot of work, not just on the machine learning side or the data science side, but it's really going to be the traditional evidence-based medicine to alter behavior side.
And to that regards, Suraj, also, I feel like, I mean, we are just looking at the ECG and maybe not looking in isolation, but taking up all of the biophysical sensors and data that really can streamline the phenotype of the patients. I think there's a lot of work that needs to be done. I can imagine a lot of busy academic outputs related to those. I mean, this is something that needs to be thought through, and how the modern clinics could be, and how do you ingest the information, and how the predictive modeling and how you see patients is going to be so very different in the near future. I think 4 or 5 years from now. I mean, we do not really know. We're probably just scraping the surface of all the.
Yeah. One thing I'll say quickly to that extent is I think we can't do this the way we did EHRs. I think
Exactly.
we're going to make a huge mistake, and we're going to make a huge error in the way we allow medicine to evolve if we try to adopt the same mechanisms of approach that we did when electronic health records came into play. I think we need to understand, principles of behavioral economics, the concept of how people engage with data in a live interpersonal atmosphere, and those kinds of questions are all going to have to come into play when we. And I think one of the key things is modern EHRs are ill-equipped to actually deal with a lot of these innovations, and there's going to have to be massive shifts in terms of how we engage with those kinds of computer systems, because old computer systems program in Visual Basic, which are antiquated and non-existent programming languages, and can integrate with more modern parlances in computer science are going to need to change foundationally.
And I think that's where such opportunities are. I think as a young health system, if I would say, coming off Rutgers Robert Wood Johnson Medical University with the Barnabas system really creates enormous opportunities, and bringing people like Suraj and having active accommodation from community and people with senior expertise like Jim really creates a model where we can all break some of the silos and think through this creatively. Thank you very much for everyone. We were 5 minutes over the time, but really enjoyed this very engaging panel discussion, and we look forward to more further episodes of such innovation in the near future. Thank you very much, everyone.
Thank you.
Thank you, Suraj.
Bye.
Great talk.
And good night.
Yeah.
Thanks.